Welcome to the Prescribing Opioid for the Chronic Pain Training Series for the Federated States of Micronesia Opioid Prevention and Response. The Association of State and Territorial Health Officials have developed the second Train the Trainer video to help you understand what to do when pausing to facilitate activity or discussion in the curriculum. If you have not already watched the first curriculum overview video, please watch it and all other trainer videos before conducting any training session. As a training facilitator, you will oversee FSM's curriculum for prescribing opioids for chronic pain, group discussions and activities, and field questions from providers. To answer questions accurately, facilitators must become familiar and well-versed in the CDC guideline and FSM training materials. The CDC guideline provides best practices and relevant and timely prescribing advice to treat patients with chronic pain. If you get questions that you can't answer, note them, then follow up after the session. Consult the CDC website or contact ASTHO. The curriculum promotes active dialogue. As such, any breakout group activity should have no more than 5 participants. We are providing suggested times for small group activities in the training videos, but these will vary depending on participants' level of engagement. This video provides instructions on what to do when prompted to pause for group discussions, activities, and knowledge checks, taking you through each step by step to ensure a successful training experience. Patient scenarios are included to get the discussion going. In this video, we will walk through the 3 small group activities in the curriculum. Trainer prompt number 4 located on page 8, trainer prompt number 5, page 11, and trainer prompt number 9, pages 17 and 18. For a quick reference of the patient scenarios and knowledge checks for Pillar 1, 2, and 3, turn to Appendix C, pages 30 to 31. Later, we will show an example of a small breakout session to help you see how to conduct a group activity. Every training session will need supplies such as flip charts, pens, or pencils. Let's take a look at the first group activity on page 8. As a training facilitator, you will instruct participants to organize themselves into groups of 3 to 5 people. Take 1 minute to get everyone situated into breakout groups and ask each group to identify 1 person per group to write down, summarize, and share the group's responses. It should take about 5 minutes to discuss the 4 Pillar 1 questions. Turn to page 8 or Appendix C to follow along. Question 1. What are the challenges with using non-opioid therapies? Question 2. Are there other referral sources if you have a physical therapy shortage? For example, chiropractors, acupuncturists, massage therapists, or others. Question 3. Are there home remedies or cultural practices that you frequently encounter? Are any of these potentially dangerous? Question 4. How do you counsel patients who may have preconceived notion that over-the-counter products such as NSAIDs and Tylenol do not work? After approximately 5 minutes, the volunteers identified by each group should spend 1 minute sharing their group's responses with everyone. As a trainer, note all replies on a flip chart or board for everyone to see. Next, introduce patient scenario 1 in the curriculum by reading it aloud. Sam Schaefer is a 63-year-old diagnosed with osteoarthritis. During a routine exam on January 27th, Sam complained of left hip pain and received a recommendation for over-the-counter acetaminophen. On June 13th, Sam scheduled another office visit due to ongoing pain. An X-ray revealed hip degeneration. Naproxen was prescribed. Give your breakout groups 2 minutes to discuss the best treatment action. There are 4 options. Ask them to reach a consensus on the best treatment plan for Sam. A. Recommend an opioid prescription to deal with chronic pain. B. Recommend they see a physical therapist. C. Discuss non-opioid treatments such as NSAIDs. Or D. Recommend bed rest. The preferred treatment for Sam is B. Recommend he sees a physical therapist. And C. Discuss non-opioid therapies such as NSAIDs. Providers should consider opioid therapy only when it will help with improved pain relief and function. The second group activity will have participants role-playing as patients and providers, presenting pain symptoms and counseling strategies. They will consider opioid selection, dosage, duration, follow-up, and discontinuation. To follow along, refer to Appendix C, the Pillar 2 knowledge check located on page 30. Pause when the curriculum prompts you to stop for the second group activity and knowledge check. ask participants to organize themselves into groups of 3 to 5 people, then direct each group to identify one person who will write and share their group's responses with the larger group. Individuals playing the role of the patient can share things like their pain level outlined by the pain scale, what remedies they have tried, over-the-counter or prescribed, dosages, duration, and any drug side effects. Ask the providers in the group to share how they would counsel the patient, their approaches, and prescribing recommendations. After this activity, guide participants to use the materials to calculate the dose and morphine milligram equivalent, known as MME. This information can be found in the resources section on page 11 of the participants' training manual under Calculating Total Daily Dose of Opioids for Safer Dosage. Ask participants acting as providers to calculate drug dosage and morphine milligram equivalent of several different opioid agents they might recommend to the patient for pain. If technology allows, use a computer and projector to play the CDC's Module 1 video addressing the opioid epidemic Recommendation 7 scenario. The link can be found in the references section on page 26 under CDC Module 1. Click on the menu and select Recommendation 7 Scenario. To play the video, when the video ends, ask groups to spend 2 minutes choosing and discussing the answer. If unable to play the question from CDC's Module 1, trainers should read the following patient scenario to the training groups. Have them refer to Appendix C, Pillar Knowledge Check 2, page 19 of their curriculum. Joe approaches his doctor and explains that the prescribed medication is not keeping the pain down. The doctor then prescribes low-dose extended-release oxycodone, a powerful drug with some risks, and lets Joe know he'll have to come back for a follow-up visit to assess how he's doing. Ask each group to take 2 minutes to decide how soon the doctor should schedule Joe's initial follow-up appointment. Your choices are A, within 1 week, B, 90 days later, C, after 2 months, or D, 5 weeks from today. The preferred answer is A. Patients should schedule a follow-up within the first week. The CDC recommends that an initial assessment occur 1 to 4 weeks after starting opioid therapy for chronic pain. We will now review the steps required to facilitate the last small group activity and knowledge check. This activity will ask trainees to consider the story of a patient who is misusing opioids and is at risk of developing an opioid addiction. Again, ask participants to organize into groups of 3 to 5 people. Again, each should select one person to share their group's response with the entire training group. Once organized, direct groups to Appendix C, the Pillar 3 Knowledge Check on page 20 of their training curriculum and page 31 of yours. First, instruct the groups to practice the questions to identify patients at risk of substance misuse. Guide participants to the resource handouts and links in the curriculum. They are listed here. They include Appendix F, ACEs, Appendix G, the pain, enjoyment, general activity, or PEG, scale, H, ACE questionnaire, I, drug abuse screening test, or DSAT-10, and J, the Alcohol Use Disorders Identification Test, or AUDIT. Next, have participants practice how they would handle a patient who is misusing opioids and risk for developing an opioid addiction for 5 minutes. Finally, ask each group what it thinks are the most effective strategies. Practice how they would handle a patient who is misusing opioids and at risk for developing an opioid addiction for 5 minutes. Finally, ask each group what it thinks are the most effective strategies. Several resources are available to providers and patients when discussing pain, prescribing opioids, addiction, and substance use disorders. The curriculum includes a resources section consisting of references to clinical resources that can help determine pain level and threshold, adverse effects, and withdrawal symptoms. Refer to Trainer Prompt number 8, page 15. In this section, patient-centric resources are listed, including the American Society of Addiction Medicine Guide, a list of commonly abused drugs that can lead to substance use disorder, and a summary of frequently asked questions. As the training facilitator, we recommend you review these resources prior to your first training. After 10 minutes of group discussion, ask each group to report out what trainees thought were effective strategies. As each group shares its responses, write them on the training flip chart visible to all participants. Next, ask people to refer to Appendix C, the PDMP handout. Review it together. As trainers, you will want to become familiar with the Prescription Drug Monitoring Program, or PDMP, before conducting any training session, so please review the additional resources at the end of Appendix E. Opioid Epidemic and Health IT, Colorado PDMP Program Overview, Colorado PDMP User Guide. Begin the third patient scenario by reading it aloud to the group. Mary, I think we should try an opioid to get your pain under control to achieve more progress towards your goals for function. We've talked about the risks associated with these medications, so before I write a prescription, I'm going to ask you to take a urine drug test, and there are some other things we should cover as well. Ask the groups to spend 2 minutes discussing the best response to the following question. Which of the following should the doctor do before prescribing an opioid? Select all that apply. A. Ask the patient about the use of prescribed medications. B. Ask the patient about any drug use, including those not prescribed by a provider. C. Explain that urine drug testing is done for all patients before beginning opioid therapy. D. Start with a relatively inexpensive immunoassay panel for commonly prescribed opioids and illicit drugs. E. Ask the patient and toxicologist about unexpected results. F. Use confirmatory testing with specific testing as needed. After 2 minutes, ask each group to share their responses. Finally, share their appropriate response. All answers are correct. The CDC recommends all patients starting opioid therapy for chronic pain undergo urine drug testing. These tests can provide information regarding drug use that the patient may have not reported, either intentionally or not. Okay, let's break into small groups. I want 2 volunteers to play the patient and provider scenario in each group. After the role play, each small group will discuss and report their best practices for each treatment.
I'd be happy to act as a provider.
Great, then I'll be the patient. I'll get us started. My lower back pain just isn't getting any better, and it's challenging for me to get moving in the morning. I've had a tremendous amount of work and been under a lot of stress. I've suffered from severe to sometimes debilitating back pain daily for the past 6 months. What's worse, it's at the same time every day.
I know you've been dealing with this issue for a while. Tell me what you've done to address the pain.
I've tried physical therapy, plus some graded exercises to stay active and to move around as much as I can. Yoga didn't do anything for me. I've also tried water aerobics and relaxation therapy. On top of that, none of the 3 medications you prescribed have helped much either. First, I took acetaminophen 3 times a day for a few weeks. Then, I tried taking naproxen twice daily for a month. Switching to duloxetine didn't help much either.
I understand your frustration. Let's work on this together. Considering your persistent pain and limitations in function, which we report have not improved with non-opioid and non-pharmacological therapies, initiating a discussion of opioid therapy is reasonable. Establishing goals for improvement and setting realistic expectations of therapy, including a plan for discontinuation, will be important next steps. I'm also thinking that acupuncture might help alleviate some of the pain you're experiencing. Let's discuss what you feel you should be able to do but can't right now. What number from 0 to 10 best describes your pain in the past week?
My pain level is an 8, interfering with my ability to work and care for my family at home. Plus, I'm always fatigued.
What number from 0 to 10 describes how, during the past week, the pain has interfered with your enjoyment of life?
I would say a 9. I haven't been able to work in my garden.
What number from 0 to 10 describes how, during the past week, pain has interfered with your general activity?
It's been an 8 all week. I rely on walking to clear my mind and stay active. I used to walk 3 times a week, but my back pain makes this less enjoyable.
You've tried quite a few things. We could consider starting a low-dose opioid that you could take in the morning to see how that works.
I'm really nervous about taking opioids. You hear such bad things.
We have already assessed for risk factors, but I want to remind you about the risks associated with taking acetaminophen. which is this opioid formulation. You shouldn't take any additional acetaminophen while taking this opioid. You should also be aware of some potential side effects associated with opioid use. These include sedation, dizziness, nausea, vomiting, constipation, physical dependence, tolerance, and respiratory depression. You shouldn't drive until you know how the dose will affect you.
It would be best then for me to start on the weekend and see how it goes.
Yes, that's a good idea. We'll start with a 4-day trial to see how it works for you and whether there are any prohibitive side effects.
Thank you so much to those who volunteered to be a provider and patient in this discussion. Based on your group's patient scenario, take a moment to discuss the most appropriate next steps, including therapy.
Considering the patient's present condition and medical history, I would suggest best practice includes administering a PEG assessment for a benchmark, establishing treatment goals, recommending acupuncture, and discussing the initiation of opioid pain medication.
I agree. For appropriate opioid therapy, I would suggest the lowest effective immediate release opioid dosage and avoiding extended release opioid when initiating opioid therapy.
Assuming the patient agreed to begin opioid therapy, we discussed the following approach. Always use caution when prescribing opioids at any dosage. Start with the lowest effective dosage and increase by the smallest practical amount. Review benefits and risks, as well as other pain therapy options with the patient. Present the option of tapering down or off of opioids when indicated.
Great. Thanks for sharing, everyone. I hope you found these exercises helpful in determining the next steps for treating a patient experiencing severe pain. We will keep all the group responses on display on the flip charts for everyone to go back and review at your convenience. We hope this dramatization is helpful as you prepare to conduct group activities in the Prescribing Opioids for Chronic Pain training. You have reached the end of this Train the Trainer session focused on facilitating group activities and knowledge checks. As you begin to hold your own trainings in the Federated States of Micronesia, please reach out to us at sph@astho.org with any questions. In the next Train the Trainer supplemental video, we will take a look at frequently asked questions and how and when to respond to questions. We will also show you how to administer the pre- and post assessments.